I thank the AIOS and the panelists for the great opportunity to speak from this podium. I am Dr. Ravindra from Visakhapatnam, Shankar Foundation Eye Hospital. So I'll be speaking on what we all do by reflex, the customization of phaco-parameters. And each of our journeys is unique. There are so many factors actually. So when I set forth to write this series, I found that there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Finally, only the surgeon is coming. So irrigation aspiration is such an important part. Here we have to understand whether each of our machine is having the linear flow in the vertical direction and also in the horizontal meridian. Sometimes even in the vertical position, we can do further customization to get something similar to non-linearity or three-dimensional aspects. That is something I will show you towards the end of the presentation in a video. Now, after the irrigation, what comes is aspiration. And it is set in flow. And what is the purpose of the aspiration and flow? The direction of flow, it is built up of vacuum. And then we initiate the phaco-emulsification in the third phase of the foot pedal. In many of the cases, we may not even require the phaco-emulsification stage for the cracking to be done, and even the aspiration. So when we spoke, the foot pedal has to be understood. The foot pedal physically can have vertical movement and also the linear movement. Most of the horizontal movement also, but most of us prefer linear movement. But the control is done by the machine console, whether it is set to linear or whether it is set to non-linear mode should be understood. Sometimes it will be a three-dimensional way, a mix of linear and non-linearity. And it is very useful to understand these things and use it at various situations. So how vacuum is rising, how phaco-parameters are rising with time, and the mode of the position, mode or the position of the foot pedal is to be understood. So with a 8-minute presentation, it is not possible to go into much detail, but it is important and it is to be practiced from the simple maneuvers to the complex maneuvers. It is like a exercise of the mind and foot pedal and hand-eye coordination, everything. And some of the important parameters can be offset by what is happening outside the globe. So we have to be aware of the globe pressure and whether the block is good, whether the speculum is in good position, whether it is tight and causing the problems that we are facing. And what we do has to be taking into consideration the nuclear sclerosis grade, the zonules, and the risks related to the capsule. And the incision dimensions and configurations are some of the very important things. So good form incision or poor form incision, and whether the plan is superior or temporal, and whether our surgery is causing leaking of the wound during the surgery or after the surgery. All these things are very important. And machine-to-machine factors are important. Each machine will be having somewhat different parameters. The zero error may be there, and so the 400 vacuum in one machine may not be same as the other. And there may be many phaco modulations that are unique to each machine. And we have to understand the strengths of the machine and then be able to use them. And when it comes to the supervisor support, the training paradigms and planning of workup of each case is to be very importantly, very minutely observed. And what is important to be understood is that the more time you spend in planning, the better the surgery that we will be able to do. Over a period of time, the time spent in the steps of the surgery will vary in a natural manner. We don't have to really make a conscious effort, but and then comes the way in which we do the surgery. So I will show here in the little time that is available the burst mode that is happening, that is being used here, and the 000. Look at the parameters on the left side when the cracking is being done. And you can see that vacuum preset is 550. Here, what we are using is a longitudinal mode that is reducing with foot pedal and a torsional mode that is increasing with foot pedal. But we are not at all using all the foot pedal pressure. Now here we are using the sub chop. And here we are using a flow modulation that is high in the middle part of the foot pedal. And that is why what we are doing is more efficient aspiration, and this has been possible because of the better active fluid, sentry, and all the improvements in the phaco machines. So now I am open to questions if time is available, time is permitting. Thank you, sir. If there are no questions, we'll take leave, disperse. Thank you.
Good evening, good afternoon, everyone. The next session will be ophthalmology update in Assam. So I would like to call upon Chairperson Dr. Gauri Shankar Gogoi to the dais, Dr. Jayanto Kumar Barua, and Dr. Birajyoti Goswami. Please come over to the dais. The session will be, the moderation will be done by Dr. Birajyoti Goswami. So I will hand over the mic to him. Please, sir. Let's start it.
Can I have the program? ইয়াতে অকমান সিফালে বহিব ভাল নেকি মাজত হেৰি নাই গ'ল ন স্ক্ৰীন শুড বি অন দ্য সাইডস অৰ এট দ্য চেণ্টাৰ
In the center.
দেন জয়ন্তদা অলপ সিফালে যাওঁ
Please make it full screen now.
তাৰপিছত তোমাৰ আছে ৰ'বা হা অ'কে Good afternoon. I hope that the lunch has not affected our cerebral cortex, and we will be having a very good session from Ophthalmological Society of Assam. It's an ophthalmology update in Assam. So we have got fantastic speakers. All the, best speakers from the state are selected, and it will be started by none other than our General Secretary, OSA, Nilanjan Kaushik Thakur. This session will have quite a few, around 5-6 oculoplasty and ocular surface related topics, 2 very good cataract topics, and a very good innovative study by Dr. Nilud Polbora. So I request Dr. Nilanjan to come for the master this cheek rotation flap, which is done for the large eyelid defects. I would like to know how he, compromises with the complications, late complications like epiphora and ectropion, entropion by master this flap rotation.
Thank you so much. I will straight away
Each speaker is allotted 7 minutes. Please, stick to your time.
So good afternoon, everyone. My topic is master disc cheek rotational flap, a solution for lower lid defect. It's not moving. Okay. So reconstruction of full thickness defects of more than 2/3 of the lower eyelid after tumor resection is really very challenging. So we all know that lower eyelid reconstruction is a dual plane reconstruction. So we need to reconstruct the 2 lamellae, the posterior lamellae and the anterior lamellae. Now, master disc cheek rotation flap is a good choice for reconstruction of the anterior lamellae. For posterior lamellae, we need some mucocartilaginous graft. So as this master disc rotational flap can be used for moderate to large full thickness defects. It has got excellent cosmetic and functional outcomes with low complication rates, and it is a versatile tissue. But definitely there can be ectropion formation. So there can be late lateral sagging and contraction of the flap, which can lead to ectropion formation, cosmetic issues, epiphora, etc. Now here are some of the studies they have highlighted that master disc cheek rotational flap has got good functional and aesthetic outcomes with low complication rate. Now this is a patient, I'll show one of my video, is a patient with basal cell carcinoma involving the right lower eyelid. And we plan for excision of this tumor along with the right lower eyelid. So now, see, this is a multidisciplinary approach. We need the nasal cartilage for reconstruction of the posterior lamellae. So here, my ENT colleague is helping me out with the extraction of the nasal cartilage. Now, 5mm surgical free marking is done with the caliper. And you can see, this is another marking which starts from the lateral canthus in a curvilinear fashion, going as high as the eyebrow and extending in front of the ear. So this is done in order to prevent the late lateral contraction of the flap. Now incision is given and this section is carried out. Can I fast forward it? So see, you can, we have excised the whole tumor along with the lower eyelid. Now this incision is given along the lateral canthus, going as high as the eyebrow in a curvilinear fashion and bringing in front of the ear. So this is because we want to prevent the late lateral contraction of the flap. Now dissection is carried out in a subcutaneous plane, but here you should be very careful that you don't injure the facial nerve. So now we are reconstructing the posterior lamellae with the help of the nasal cartilage. So this is very important. We can take it post-auricular or from the nasal cavity. So we have taken from the nasal cavity. Now this anterior lamella is formed by this master D cheek rotational flap. So this flap should be designed in such a way that it should be properly designed and should be rotated. And first you should put a stay suture for proper approximation of the flap. It's a very large flap. So this is used for the reconstruction of the anterior lamellae. Now here we are giving a stay suture. So ultimately your post-operatively your palpebral fissure should be a narrow slit actually. So we are giving the stitches. Now we are putting a drain over here. It's a large flap, so there will be collection over there, and that will hamper wound healing. So drain is very important. So this surgery is completed. These are the post-operative pictures. Thank you so much. Actually, we had some problem because there will be epiphora in those patients, and we need to counsel these patients pre-operatively. Thank you so much.
I'd like to hear 1 minute comment from Kasturi, who is vastly experienced in this. In the meantime, I would like to request Dr. Jayanta Kumar Das, who has got another talk classing in the time, so to get prepared for as the next speaker. Jayanta, please get prepared.
Very nice, Nilanjan. Only thing, I just want to give you 2 inputs. Like, this tumor should be done under frozen section, but
yes.
I also understand frozen section is not possible in every place. So instead of repairing on the table, because it's such a big surgery, right? You can at least wait for 48 hours also. Nothing will happen. Then once you get the clearance from the pathology department that the margins are free and everything is okay, then you go for reconstruction.
Yes.
And when you go for reconstruction, is a very big pedicle flap, I should say. So always a 2-layer. This is something like a facelift.
Yeah.
2-layer suturing should be done, and not a single suture to the skin. But your results are really good, and I should congratulate you.
Thank you so much.
Jayanta, in the meantime, Nilanjan, did you have any complication of keloid?
Fortunately, we didn't have any complication of keloid in this patient.
Because it would have been so embarrassing
Exactly.
And did you have any late complication of ectropion and entropion?
No,
that is very much reported.
Yeah, that is very, very important because there can be late lateral contraction and sagging. So the flap should be designed in such a way and rotated. And for the flap incision, that's what we start from the lateral canthus and go as high as the eyebrow in a curvilinear fashion. And so that mobility of the flap. So that, and while you suture it, your just immediate post-operatively, it should be a narrow slit, your palpebral fissure. So that these are the steps you need to take to prevent the ectropia.
Thank you so much.
Thank you, sir.
Dr. Jayanta, please get ready. Dr. Jayanta Das, a noted oculoplastic surgeon from Assam. And congratulations, Jayanta, for getting the Achievers Award from AIOS.
Thank you.
And you will be taking care of a very painful, very frustrating, painful topic for ocular surgeons, that is evisceration, and how to make the best of evisceration.
So it's a very big trauma to the parents, to the patient, etc.
As well as for the surgeons.
Lots of techniques are developed, but still none of them are still fully satisfy the patient. So here I am trying one new little old, but I am trying, is not moving the slides. Okay. So I am not going for all those fact. There is a psychological factor I am talking about that. And another point is the ocular surface. In this technique, we can manage the ocular surface. We are not looking mainly the dry eye, weight eye, so many things. We can do a cosmesis with custom made. What have I? Oh, it's okay, fine now. Oh, it's not going. So that part is that ocular surface. That ocular surface is one of the big concern. With this technique, not we can spare the only cornea. Of course, we can sacrifice the okay. So I'm that or it should be functionally. With other technique, we can provide functionally and cosmetically. But psychological trauma, one factor, and I am added one. I am doing some work on that for surface. So those are the some patients are neglected in all procedures. Other evisceration, whatever scleral the quadrification, all other in intracorneal implant, the 100% volume replacement is not possible. But here we can try for 100% volume replacement because we are sparing everything. Of course, none of that in the world is 100%. So those are the list of those things. I am not going all those points. About the conjunctival surface. Here we can protect the limbal stem cell. That's the biggest advantage. Not only the cornea, limbal stem cell. Because we are giving the incision on the just a reinsert and disinsert like in any squint surgery. Of course, there is just some amount of problem is there with the conjunctiva tendons, but it is like a squint surgery. It's not like as a evisceration proper. Because in evisceration other techniques, we are doing 360-degree corneal opening or 360-degree limbal stem cell injury. But here only we can give from above without touching any limbal system. That's another beauty. Goal of these procedures, what are the goal? Well-centered orbital is 100% in all cases. Fornix or sufficient depth hold in appropriate a socket lined by all coats of eyeball, including the limbal stem cell. I am mainly considering only all coats and the limbal stem cell. The steps are, one is the corneal steps. For that we need, for a research purpose also we can use our junior colleagues, like we can deepithelize. The oculoplastic surgeon or any other surgeon can do a deepithelialization by 100% alcohol. But one important step, we should remove the endothelium. In such condition, generally I might call my junior colleagues to do like a dissect. They can strip that endothelium by their own system. That's one biggest advantage. We can teach my junior student and then my junior colleagues for squint surgery because some steps are like a squint. This insertion of the superior extraocular muscle like superior oblique, or in some cases if there is scleral trauma, then on that particular area I can address. Does this insert that suppose lateral rectus, there's a huge scleral injury on the lateral side, so I disinsert the lateral part and etc. Steps of ocular muscles. So I am in hurry, I am just strangling thing. It is a very bad, multiple times operation was done. So here in multiple times of operation was done, but still multiple operations was done. Silicone fill eye, almost 4 or 5 times surgery was done, PL negative, painful eye. In such cases also, just a point, we can just teach our juniors to do like a superior rectus, superior oblique, what this insertion, then we can make one curvilinear. Mind it, here I am doing the incision not on the limbus. This is a very, very beauty. In other evisceration, you have to sacrifice the limbal stem cell totenicus. Then you can go and open. The silicone fill eyes comes out, silicone oil comes out. Then you can insert everything through that one. The next beauty is that, but that is technically little difficult. It's not possible for all for juniors. So with the spatula and others, we can make as per your convenience. It is a silicone fill eye, then you can even 90 degree, 80 degree sufficient. But if it is a little tricycle changes, then you may need mainly 180 degree. Again, you disinsert and reinsert. You can ask your junior to do the like a squint surgery. It's perfectly all right. Then, as like in trap surgery, you can close at that end. You can insert the ball. Here, one biggest advantage is this, that the cornea is remains same except that epithelium and endothelium. So chances of out of these 15-16 cases, one of my patient developed corneal ulcer. So we can treat that patient as in a corneal point of view. So like that we can explain there may be issues on corneal, but there will be no extrusion, no nothing, and even a low cost ball like a acrylic or whatever acrylic we can easily available, and we can implant and we can do, and motility is excellent. You see, so benefits are, I am telling all those points, I am just at wind up. So those type of thing is not available. So standard process, and we can implant that volume replacement, which is 8 mm loss. We can measure. Then here almost 8 mm we can intake with the. This is like a eye movement. If you see, look at motility where. So that is motility is there, and this is a perfectly almost all right. So that's thank you for that.
Thank you, Jayanta. Thank you for finishing on time, even with the problems. By the time we call upon Dr. Haimanti Chaudhuri to deliver her talk on dry eye analysis innovations, the recent updates, I would like to invite some clarification or questions to Dr. Jayanta by the time Haimanti prepares.
No, zero extrusion. Here, no extrusion, no migration, and no displacement, nothing. Only there may be a corneal issues. That we have need a little frequent and surface, because I am giving the incision from very up. So all limbal stem cell preserved, and of course it's a difficult surgery, technically. Okay. Yes, oh, white. Yes, good. Very good question. So, as that main culprit for endophthalmitis point of view and other point of view is the epithelium and endothelium. The recent advance is not even the uveal tissue. So, main culprit is the endothelium, and the epithelium is the main part for pain, surface pain, and endothelium is the one of the triggering factor for. So, moment I remove 360-degree corneal epithelialization by absolute alcohol, so it's become white, but there will be no pain.
Okay, Jayanta.
There will be no
Thank
pain.
you so much.
Yes.
Dr. Haimanti from Silchar is an extremely talented upcoming ophthalmologist. She is the editor of Journal of Ophthalmological Society of Assam, and she has taken up a very important subject, of very dynamic subject of dry eye analysis, which goes on coming up with, comes with newer diagnostic tools, then therapeutic modulations, and better understanding of the problem, including the meibomian gland dysfunction and inflammatory biomarkers and whatnot. So we would like to know some innovative analysis process from Dr. Haimanti.
A hearty good afternoon to one and all present here. At the very outset, I'd like to thank Chairman Scientific Committee, AIOS, as well as OSA for giving me this opportunity to be a part of this session. I'll be talking on innovations in dry eye analysis. It's not moving.
Every time it is like that, it will move.
I do not have any financial disclosure in this presentation. So basics are always basics. So before we go to any diagnostics, we have to stick to the standard clinical evaluation. And herein, the history taking has a very good role. So dry eye questionnaires are quite underrated, but they have a very good, gives a good subjective assessment of the discomfort that the patient is having. So it is quite imperative to differentiate between the type of dry eye, whether it is a lipid deficient or an aqueous deficient, because that will modulate how we want to treat the eye. So this is also very important that we make this differentiation. So ocular surface disease index questionnaire is the one that we mostly use, and we can tell the patient that it is not just a form to fill up, it is something more important, so that they will do it sincerely, and based on that we can differentiate the symptom as mild, moderate or severe. So the examination protocol that we would like to follow is first the slit lamp evaluation, wherein we do the tear breakup time, the tear meniscus height, then the ocular staining. Staining, we have the option of rose Bengal and Lissamin green, but we prefer Lissamin green because rose Bengal is little stingy to the eye. But we have to follow a standard scoring pattern, and there are many actually in literature, but whichever standard scoring pattern we follow, it is important that we consistently follow the same pattern for all the subsequent visits. Next, we do the standardized Schirmer test, and I am definitely not going to tell you how to do that. We all know. And finally, we have to do a lid eversion to know about the meibomian gland health status. When we talk about imaging in dry eye, this is a market which has boomed like anything, and you name it and you have all the new devices coming up, but then it is again not possible for all of us to purchase all of this. So then they do have a role of this multi-imaging integrated device. These are, I would say, is an addition to your armamentarium of dry eye, because they do multiple functions of interferometry, mammography, and few other functions also. So these are kind of helpful. So the device that I have been mostly using last few years is the dry eye analyzer, which has the facility of non-invasive breakup time, the tear meniscus height, infrared mammography, and lipid layer interferometry. In non-invasive breakup time, we basically project Placido's disc-paced light with white light over the cornea, and it gives you an idea about the first rupture time, the average rupture time, and it gives a breakup distribution, and it generates a heat map kind of a thing. The red, warmer colors are dried area, and the cooler colors are all right, normal areas. Coming to the next, tear meniscus height, it is done with an inbuilt ruler, which is placed in line with the pupillary center, and if it is 0.2 and above, it is normal. Anything below 0.2 is abnormal. Infrared mammography is based on the autofluorescence of healthy meibum when infrared light falls on it, and it is captured by a coupled camera. The first image is what you get, and then an image of AI is imprinted on it, and you can know about the amount of gland loss or gland dropout. The first picture is a normal meibomian gland. The second one is a grade 2 MGD with about 40% gland loss. And the third is grade 3 MGD with around 70% gland loss. The fourth function that it does is the lipid layer interferometry, which is based on the principle that when adequate white light hits a lipid layer, there is generation of interferometric fringes. The first video top left, you can see there are multiple colorful fringes, which shows that the lipid layer is normal. So this eye, the left-sided eye is the patient eye, and the right-sided eye is the sample eye fitted in the device, and the AI, what it does is it matches with the sample eye provided in the device. And the last video where you see that there are almost no fringes, so this has a very, very thin lipid layer. So this is how the interface looks like. It gives a color-coded report. And idea, we also can give the idea to the patient. This is another interface of how the oculus keratograph looks like. This is also another multi-integrated device. Another recent advance is this optical quality analysis system. The tear film optics actually also affects how we see. So what this device does is, in between blinks, it measures the scattering of light. The first picture where it is written pre is a patient of pre-cataract. Here this is a normal scattering, there is not much scattering. And the right side where it is day one, it is day one after cataract surgery where the scatter has increased. So this is an abnormal finding. I do not have any personal experience in the last two devices. Confocal microscopy, the Rohit Shetty group has done extensive studies of in vivo confocal microscopy in dry eye patients, and you see the difference. The right-sided one is a confocal reading of someone who has a normal cornea, and the left is the one with a dry eye. So dry eye, actually there appears a lot of dendritic cells, which are basically signs of inflammation, and also some other abnormal nerve looping and keratocytes. These have been described by the Rohit Shetty group. Thank you very much for your kind attention.
Thank you, Haimanti. Just on time. As we call upon Dr. Arundhati for another case of ocular surface disorder, Dr. Haimanti, would you like to clear some doubt if there is any? Is that working? Both sides working? Okay, that's fine. Dr. Haimanti, as Dr. Haimanti has very clearly stated, actually all these, you just name it and you get it. So many innovations, so many diagnostic tools. Most of them are qualitative, but quantitative assessment is done only by tear film osmolality, which if less than 308, it is early, 308 to 12 millimole, it is moderate, and above 312, it is severe. Others do not have that quantitative, the grade assessment. We can always have a better understanding of the pathology, but we cannot grade it very correctly. So we would like to shift over if there is no other question. Jayantara, is there any question? Okay. We'll like to request Dr. Arundhati. She is another prolific and, she is doing almost all sorts of surgeries of anterior segment in a very refined way. And we are really proud of you, Arundhati. We call her Polly. This is an MMG in desperate case of bilateral severe OSD.
Thank you, Virajda. Good afternoon. I'll be discussing a case of bilateral severe case of ocular surface disease where I have done mucous membrane grafting. So whenever there is posterior migration of mucocutaneous junction, it leads to lid margin keratinization, which commonly we see in case of Stevens-Johnson syndrome and toxic epidermal necrolysis. This is a condition which doesn't revert on its own and doesn't respond to the medical treatment. So here, mucous membrane grafting is the only procedure by which we can arrest the pathology and causes restoration of the ocular surface microenvironment. So here what we do, we replace the keratinized lid margin along with the adjacent tarsal conjunctiva with a healthy mucosa, and most commonly we harvest from the buccal mucosa because it is easy to access, and secondly we can go for repeated harvesting without much of complication. Other site from which we can take is the rectal, vaginal and also nasal. So by this mucous membrane grafting, we can do a restoration of the normal ocular surface, thereby improving the visual function. So my case is a 30-year-old lady who came with the late sequelae of drug-induced Stevens-Johnson syndrome. She gave a history of skin eruption followed by blurring of vision since her early childhood, and she has undergone lid surgery once and also mucous membrane grafting 12 years back in her right eye. And she was also advised to do undergo scleral contact lens, but she refused because of the financial problem. So when she came to me, her visual acuity in the right eye was hand movement, and left eye it was only finger counting 1 meter, and that was her only better eye. So intraocular pressure, it was normal digitally in both the eyes. When we do the Schimmer score, it was 0 in the right eye, and left eye, it was only 5 millimeter. So we did a B scan where we got a normal vitreous with attached retina and the normal optic nerve head. So this is the condition of the right eye, where we can see the lid margin is irregular, we can see the trichiatic vessels, and severely xerotic and keratinized cornea we can see, which is highly vascularized. So there was symblepharon present all around, which restricts the eye movement also. And this is the lid margin, upper lid margin, which on eversion we can actually see the posterior migration of the mucocutaneous junction and the atrophied meibomian glands. And here there is also a false pseudomembrane, which are nothing but the deposition of hyaline granulation tissue and the inflammatory cells. So that was her right eye. And in the left eye, here we can see there was a BCL is already, she was putting a normal BCL with some deposit on it. The cornea was vascularized, there was scarring. And this is on the eversion of her upper lid. We can see the keratinized lid margin. And this is the lower lid, where we can actually see the extent of the lid margin keratinization. So we decided to go ahead with the mucous membrane grafting, followed by scleral contact lens in her left eye. So the video quality is little poor. Here we can see we have taken the donor graft from her labial mucosa. Ideally, we take around 25 by 10 millimeter graft. And after removing the fatty tissue and the blood vessels, we made the graft. And this is divided into 2 pieces so that we can put in the upper lid and the lower lid to cover the lid margin. So here we can see this is normally, ideally, our intention was to cover the central, cover the cornea. So we ideally take a 20 to 25 millimeter of graft size, and then it is then sutured with a 7/0 Vicryl. So this is the graft, and we only stitch the upper portion. The remaining of the area we attach with the glue, or even then we can also use the patient's own blood to give the for the attachment. So post-operatively, we advise to take do gurgling with the hexidine mouthwash after every meal for 2 weeks. And she was also advised to take analgesic gel before taking any meal. Then topical antibiotic along with a steroid in a tapering dose. It is given for over 6 weeks, along with frequent use of lubricating as usual. So this is the post-op picture of the mucus once after the removal of the suture. You can see the graft is well seated and it is vascularized. So after that, we realized that the patient has gained improvement in the symptoms, and also she was symptomatically better. She had her vision has also improved after putting the scleral contact lens. So to discuss it, we get 90% success rate in restoring the ocular surface was reported following mucous membrane grafting. And oral mucous membrane, as I said, it is the best suited for the surgery because of the easy access compared to the other sources. And we can use a fibrin glue of a short operative time but comparable outcome as seen in sutured surgery. So to conclude, it's an effective treatment for the lid margin keratinization, especially in SGS patient, which offers significant improvement in patient outcome while minimizing the surgical complication. Thank you.
Thank you, Arundhati, for such a beautiful talk. By the time Dr. Dipankar Das prepares for his talk, would you like to stay there? Is there any question? I have got a question.
What about the graft site? Do you have to stitch it or leave it like that?
No, the upper part, like upper margin, we have stitched with the Vicryl. The lower part, we have applied fibrin glue.
No, about the graft site, from where you have
No,
taken
we
the...
stitch it. We stitch it.
You have got a symptomatic relief.
Yes, patient
Very
was
good
much
symptomatic
better,
relief.
and,
Now,
we did the
how do you plan to go for an optical relief? I mean, visual improvement. Do you plan for a K-Pro?
No, we put scleral contact lens, at least
Later on.
Later.
I mean, how to remove the scar, corneal scar?
This after putting the steroid, the vascular, we have seen the vascularization, even the scarring per se, it has reduced.
Okay. Okay.
Pardon? No, amniotic membrane cannot be used. This mucous membrane we are using because we are trying. So normally what happened, the keratinized lid epithelium, it has a viper-like effect, no? It causes microabrasion of the corneal surface and leading to damage of the ocular surface. So by putting a smooth membrane, it helps to regain the ocular surface.
Here, which one lubricant you use?
I use, normally I give normal CMC only. I don't go for sodium hyaluronate.
I'd like to request Dr. Kasturi to add something.
Arundhati, it is a very nice initiative. Just 2 points I'd like to add here. This SJ is a very restrictive fibrotic pathology. So whenever we do such operation, because what is the maximum long-term follow-up in this patient?
This is almost a year, 1 year.
But usually what happens, you need to split in the gray line. Okay, so you have to separate the anterior and the posterior lamellae, because you have mentioned these are posteriorly migrated posterior lamella.
True.
So you have to do anterior mobilization of the posterior lamella. So this is the splitting you have done, right? Two layer. So you have to do anterior mobilization of the posterior lamella, and there you have to put a graft.
Fantastic.
Then that is number one. And when you do an anterior mobilization, how do you fix it? So you need to put the forming suture here. It's clear? Supposing these are the eyelashes, so anteriorly separated, anterior mobilization, fix the anterior lamella here and put the graft. Supposing in SJ's patient, even it is difficult to get the mucous membrane of the oral mucosa also.
Yes.
Then the next option is PRF. PRF is you draw from your blood, centrifuge it, and after some time you will find a very thick fibrin membrane. So now what I'm doing, I'm using PRF and the results are equally good, provided you do this separation and mobilize the posterior lamella. Okay, so if you add this, then it will be a much,
Regarding the first comment, I would like to say, normally we try to put the incision on the gray line, but in some cases it is not possible. In those cases, we look for the this posterior, that mucocutaneous junction. So that is helpful. And the second thing I have never tried of, like what you were saying, no?
In
So
case, because the mucosa affected in SJS,
In
so
those
you can use the PRF.
patient we won't be able to do.
Or multi-layered, what Nilanjan has mentioned,
amniotic
multi-layered, one
membrane.
after one. Okay?
Thank you, Dr. Kasturi, for such a important addition. Now, Dr. Dipankar, the researcher of, ophthalmic researcher of Assam, in the purest sense of the term. And we'd like to learn a topic which is also new for me, doing cornea for such a long time, using green laser in fungal ocular infections. Dipankar, it's all yours.
Thank you, sir, for this generous introduction. I'd like to thank APAO, AIOS, and Dr. Namrata Sharma, Chairman Scientific Committee of AIOS, and OSA for giving this opportunity to present my topic on use of green laser in ocular fungal infection. Myself and the co-author who were involved did not have any financial or commercial interest in any of those material discussed here. This is purely an academic one. Now, this is a well known for all of us when you see a dry looking corneal ulcer. The next point is that we do a scraping and send a specimen for KOH. What we innovated is that to do a fluorescent stain, and here you see those are the drug particles. After removing the drug particle and put a fluorescent, the fluorescent that is solution fluorescent, then the fungus were visible. And this we published in Indian Journal of Ophthalmology as a fungal corneal ulcer stained with fluorescent stain. Now again you see this is again a dry looking ulcer. Now scraping was done. It shows a septate fungus. Now the therapeutic keratoplasty was done. Then it was cultured, and this in the middle you see fluorescent stain with all conidia of Carbuleria. And this was further done in the right side picture with a lactophenol cotton blue sweat in microbiology department who showed a conidia fungus. Third scenario is that this is a uveal specimen of eviscerated specimen showing uveal tissue, cornea with PK suture, IOL and vitreous. And when we did a fluorescein stain, we saw fungus on the IOL and the fungus in the vitreous. This in 2020, we published a fluorescein dye as a novel cost-effective approach for staining raw specimen in ophthalmic pathology. And these were compared with the conventional Groker-Smith-Norman silver staining. Can we visualize microorganism without a stain? That's a big question that we ask ourselves. There are various uses of laser in ophthalmology. Currently, microbiological staining in laboratory are the diagnostic modalities for detecting microbes. The objective of the study was to analyze the effect of laser in different fungus for their detection. Now, see, the pointer class 3 laser product was used, complied with 21 CFR, wavelength of 532, were used in laboratory setup, and objective of compound microscope JEISS Exoscope 40 made in Germany, and without taking any microorganism. Important thing is that to protect our eyes, there's a shutter is there so that rays does not come, and necessary eye protective measures were taken. Raw specimens were studied. They were examined in the monitor of computer attached to the microscope and photographed in the Exoscam MRC camera. These are the clinical picture. These are the eyes that came to the cornea department, but I have collaborated with them, and see these all are in my cameras that I have documented them with a solution fluorescein stain. When you use a strip, you do not get the depth of the thing. So this is one point you can use with a fresh solution that you can get from angiographic room. Now, 2 years, total 15 cases of mycotic corneal ulcer were studied, 5 cases of aspergillus, 4 cases of fusarium, 4 cases of carbulia, penicillium in 2 cases with green laser. Results were compared with conventional staining. Now we see in this clinical picture, KOH was done immediately in the scraping, and in our lab we have done fluorescein stain in those cases, and GMS stain, if you see, was done in the permanent section. All this green laser was seen in our microscope. To discuss it, label-free fluorescence is based on autofluorescence originating from endogenous fluoropores. And nonlinear microscopy has a capacity to linking a structural information of the fungus, particularly the chitin layer of the fungus. Spatial image can be acquired from point to point as in our study, and fungus can be seen in fluorescent microscope by using a chalcophore white stain. But you require a fluorescent microscopy, and I have done this in a compound microscopy. Our study showed alternative way of conventional light microscopy to detect the septate fungus. Limitation of the study was sample size was small, and further studies are larger scale are required in that vein. Now we see 2 photographs where the fluorescent stain, our innovative fluorescent stain, showed the conidia, phthalates, vesicles, types, and you see the right-hand side picture, green laser in the present study. All phthalates are so nicely picked up by the laser. Again, you see the carbulidia where the fluorescent stain already published showing the conidia, and right-hand side green laser was used to pick up the fungus. To conclude, the stainless laser and its modification was effective in diagnosing the fungus in vitro in corneal ulcer. In future, the use of properties of light, we can translate this innovation in real-time live patient fungus detection. These are my selected reference. And I like to quote that process of innovation are after a lot of basic experimental stages and scientific imagination. I like to thank Cornea Department, SSD and Ocular Pathology, and Microbiology Department. Thank you for patient hearing.
Thank you so much, Dipankar. Just stay here. By the time Kasturi prepares for her talk. So Dipankar has given a really a big potential that one day we might be seeing fungus live in corneal ulcers. And let that day be coming very soon. Otherwise, I will be not having that opportunity. Jantada will not have that opportunity. Let that time come very soon, and I request Dr. Dipankar to work very fast so that we can see that in our life.
Thank you, sir.
He's really working hard
Thank you.
and has done a lot so far. Please continue.
Now we have got the star performer of Ophthalmological Society of Assam, Dr. Kasturi. All over India, she needs no introduction, and definitely we are mostly from Assam. And Kasturi has made us proud for so many occasions, and she will navigate us through the orbit today.
Thank you, Birashta, for the kind words. And at the outset, I would like to thank Ophthalmological Society of Assam, especially Nilanjan and Abhijit, for having me here, and also AIOS and APAO. So I'll be talking on technological updates, the navigation tools in orbit. And when we mention about the technological updates, the four major technological updates are: one, definitely navigation, which I already mentioned, the others being the 3D printing, the robotic surgery, and the use of artificial intelligence and the different type of reality machine. So this navigation is today cutting edge technology for performing a very precise orbital and oculoplastic surgery, having numerous indication and with numerous machines that are available in today's market. So what is this? Basically, it is a GPS system, and this really gives a roadmap to the surgery so that we also know what is the end point of the surgery. The advantage is that we take the data in the form of CT, MRI, or MRA, and then we put this data into a system, and this gives the real-time updates, which can be where exactly we are in the orbit and what is the actual endpoint of the surgery. So here you can color code the different structures, whether it's a muscle or whether it's a fascia, whether it's a bone, and also you can incorporate both the MRI and the MRA. One of the most important advantage is the segmentation. Segmentation means you can really read one segment of the orbit, and if you want to see it, visualize is better. And secondly, mirroring, that means you can mirror the normal over the abnormal, so that once in mirror, then you know that how much amount of the volume changes occurred following a fracture. And this is merging of the two CT, one above the other, and this will really give you the extent of the fracture, and also it will help you identify defect, to quantify the displacement, and we go for the patient-specific implant. We use it extensively for both the orbit reconstruction following the orbital fracture, and especially when there's a fracture of both the horizontal and the vertical buttresses of the face, and especially when there are different types of complicated fractures like the impure fracture, where you see a fracture of the wall and the fracture of the rim. And this is today one of the most advances, and really it gives one of the best results when we go for reconstruction of either the orbit or the face, because you know where to end. Where to stop, that is what we have learned when we do a cataract surgery, and where to end is very important in oculoplastic surgery. So here, as I have already mentioned, you have the data in the form of the CD, MRI, and this is a machine. This is a machine where you put the data, and once you put the data, you can segment it and you can read it, you can color code it, you can have a different software like a bone window software, the 3D software, and you can read exactly what you're doing. So you create an electromagnetic field. So within this electromagnetic field, you have a stylet, and during the surgery, once you use the stylet, they will tell you whether in the enter orbit or whether you're in the optic canal, or whether there is an important blood vessel or a nerve near your part of surgery. So this is what I was mentioning, mirroring. Mirroring means if you see the left side, you can see the green is a normal orbit and the yellow is a fractured orbit. So because of the fracture, you can see so much of volume enhancement, which is the cause of inophthalmos. So you can measure exactly how much is the volume loss, because it's not possible to have a PSI, which is such a costly affair in the orbit reconstruction. So if preoperatively you know how much amount of the volume loss, you can exactly plan the surgery surgery, and this will usually tell us where actually in the surgery. So as I have already mentioned, an electromagnetic field is being created, and this is at the beginning of the surgery. You'll see the blue, this is the stylet of the navigation probe. So before the starting of the surgery, it goes directly into the maxilla because whole of the inferior orbital wall is been fractured. Then once you start doing the surgery, you see where is the fracture end, and then you put an implant. Now you should know whether the posterior ledge of the fracture has been covered or not, and whether you have done the appropriate volume replacement. So this is the implant where I am keeping both medially and inferiorly, and once this is being done, this is a mixture of titanium and a Medpor implant, and you screw it to the proper position. Now you'll see I'll again use my stylet to know whether my stylet goes into the maxilla or in the orbit, or whether it's a correct plane. So as I move the stylet, now you can see the stylet is on the green. That means I am in the correct plane. I have done the adequate amount of volume reconstruction, as you can see here. And this is just, I'll go fast, this is again under the surgery. So for a very simple surgery, you may not need to do very much, but for a complicated surgery, it really helps it in order to, if you want to give a more refined reconstruction. So for a complex fracture like this, so you can see there's canthal dystopia, there's volume loss. It is a big fracture because the slide before this, if you see, I don't know whether it'll move, you can see, if I go back, you can see such a big, and there's such a big surgery has been done, and you can give him a very adequate correction, as you can see here. And sometimes this looks a small fracture, but you can see just up to the orbital apex. The whole fracture has gone up to the orbital apex. And this is here I'm using a very important different type of material, which we call as a PCL material. This material which will stay for 2 years, and after that it gets replaced by the body's own bony tissue. So this is something advantage, because when we use the titanium, it is a metallic product, right? It's inert. But this gets replaced by your body own tissue, and this is something, and this is done under navigation surgery. Can you see before the surgery the eye does not move, and after the surgery there's so beautiful movement, and this corrected her diplopia in the primary gaze. Another gentleman, as you can see here, the same implant has been used. No, it is not moving. Yeah. But this is a surgery, and because he has too much of volume loss, so along with this, I have also put a titanium implant, and this is a navigation at the end of the surgery. I'm rechecking whether I have reached the posterior ledge, whether the posterior ledge has been created, and this is what you see before and after the surgical procedure. So in all this type of complex surgery, like which you have already seen before the start of the surgery, as I'm measuring, you can see the whole of this navigation probe is within the maxilla. And this patient doesn't have any floor. So floor has been reconstructed with a titanium sheet, and then I had to use a mid-face implant in order to give a mid-face. So this is once you place the stylet, you are sure that you are in the appropriate position, and this is how the patient comes with a total globe luxation, and this is approximately a month, and then approximately a year, you see a much better correction. AIOS fracture is something different, where you can see the fracture of the nose, orbit, and ethmoid. So these are really challenging situations. So I'm closing here. So with this, I'd like to conclude that this navigation advantage is that this really gives you an endpoint of the surgery. You can do a very precise surgery, and the most important thing, that it is safe to your tissues. You know where the nerve is, you know where the blood vessel is, and it is extremely safe, and it is one of the most advances in orbital reconstruction. So with this, I conclude. Thank you very much for your patient hearing.
It was really very heartening for me to remind you of the time, but because it was such an absorbing one, but time doesn't allow us. Now we move to Dr. Swaraj Bhattacharya, the General Secretary of IJOC and also past General Secretary of Ophthalmological Society of Assam. So, immediate past General Secretary of IJOC. Anyway, now we will be having two cataract related topics, and first will be by Dr. Swaraj, next will be by Dr. Abhijit, and two hurdles in cataract surgery, how we move on the hurdles.
So good afternoon, everybody. My sincere thanks to AIOS Chairman Scientific Committee, Dr. Namrata Sharma, to allow Assam to be a part of the program, and our CSC, Dr. Avijit Hendik and Dr. Nilanjan, to include me in this forum. My topic is erratic, unpredictable people puzzling out of the riddles. No financial interest. Erratic behavior of the people may be in the form of small people, iris prolapse, intraoperative floppy iris syndrome, reverse pupillary block, or iris lens diaphragm retropulsion syndrome. The small people, how small? 4 millimeter or less. 1.4% of the all cases comes to this category, and all steps of surgery becomes difficult. Now, how do you differentiate a small people? It may be elastic or a rigid. Putting a visco or BSS, when there is a temporary expansion, as for example in IFS, if it is a rigid, there is no expansion, as for example in pseudo exfoliation. Now, the elastic people serves like this, stretchable one, whereas rigid and fibrous, it is breakable. How do you manage? Preoperative with NSAID drops, intracameral adrenaline, viscodilatation, multiple sphincterotomies, synecholysis. Iris management done by the iris retractor or the iris expander. When there is iris prolapse, it occurs during phaco or cortex removal, more likely to prolapse when there is a lack of tone as seen in IFIS, inadequately dilated people, a poorly constructed clear corneal incision, and a shallow anterior chamber. However, the reason is always a pressure gradient. Anytime the pressure behind the iris is more than the pressure in front of it, the iris will tend to prolapse out of the incision, and treatment is neutralize the pressure gradient. How? By lowering the pressure behind the iris or raising the pressure above the iris, and iris will return back to its normal position. Now, IFIS, intraoperative floppy iris syndrome, it was identified in 2004 and published in 2005 by Dr. David Chang. We are seeing him in a very good move in the conference here, especially associated with the tamsulosin, the most commonly used drug for BPH. The signs are there is a tendency for the poor pupil dilatation, along with the bellowing of the flaccid iris stroma, a propensity for the iris prolapse towards the phaco and side port incision, and progressive intraoperative pupillary constriction. The most commonly seen complications are iris trauma, posterior capsular tear, and vitreous loss. Why Flomex? It relaxes the smooth muscles of the bladder neck. Similarly, it acts on the iris dilator as well. By specifically targeting the alpha-1 receptor, and blockade of this receptor makes the conventional dilator drops ineffective. What are the predisposing conditions by the use of medicines like alpha-1 receptor antagonist, angiotensin, ETR antagonist, and so on, even with a systemic disease like chronic heart failure, diabetes, and systemic hypertension. So even the best of the history taking failed to prevent IFS, so stay vigilant, act promptly and safely for the best outcome. It results from a combination of inhibition of iris dilator muscle causing meiosis, degeneration of the long-term dilator smooth muscle causing floppiness, and there is a strong affinity of the systemic medication which binds to the iris pigment granules. We should remember, even after 1 year of stoppage of tamsulosin, it can occur. Even after 3 to 4 days of use of tamsulosin, it can occur. And stopping tamsulosin preoperative is of unpredictable and questionable value. How do you mechanically dilate? Pupillary stretching is not effective in IFS as it is in elastic people, or it may be a controlled stretching before expanding as in case of rigid people by the use of iris retractor and the pupillary expansion ring like BHAX ring. It prevents it from constricting and restraining the iris from prolapsing. I'd like to share a very small video where a 64 years old patient, moderately dilated people, using tamsulosin for BPH. Here in this case, we are anticipating IFS. After putting the iris hook 4 or more to make the pupil hexagonal, making the corneal tunnel little longer to avoid the iris prolapse, we can continue with the phaco, and after the procedure, gradually, we take out one by one the iris hooks. While taking out, care must be taken not to disturb the endothelium. There is another case, here 62 years old BHP using medication, and add on there is a pseudo exfoliation. In the same procedure, here again we are using the iris hooks, 4 to 6 may be used, just to make sufficiently dilated to make the pupil phacoable. And then Rexis tunnel and so on. Pupil expansion ring like Milligan ring, I'm not coming into details of it. Then BHEX ring, which are most commonly used nowadays by us. 60 years old male using tamsulosin for BPH. Here in this case also we are anticipating IFS. Here, after a long corneal tunnel, we are using a BHEX ring, and this has been introduced with a 2.2 millimeter incision with a 23 gauge forceps, and the flanges with the hooks, with the holes are placed below the iris, so beautifully hexagonal shape pupillary comes, and we can continue with the surgery in a very comfortable way. Once the surgery is finished, after the IOL introduction, very carefully flanges are released slowly, taking care of the endothelium. See another small video of a small...
Dr. Soras, would you please summarize?
Okay. And one more condition is the reverse pupillary block or iris retropulsion syndrome. Here in this case also, I'm just showing a small video, that's all, I'm finishing it. See, while doing hydrodissection, the anterior chamber becomes deep and the pupil dilates. Once you touch it, it comes back to the normal position. So what are the take-home points? Iris may behave erratically at any point of surgery, but with adequate pre- and par-operative measures helps to manage the situation comfortably. Proper armamentarium must have backup IOL, iris expander and CTR if the situation demands. And thank you for a patient hearing.
Thank you, Soras. Very illuminative talk. Dr. Abhijit, would you please come over? And I would like to request Dr. Jayanta Barua, who has got vast experience in phacosurgery, to give a short comment on it.
People is a structure that we got to respect in a phacosurgery. It's quite unpredictable. Any people below 7 millimeters of less than 7 meter dilated, we should be suspicious. Although any people above 4 millimeter, we can do phaco without using any dilators. Yes. But we have to be careful in people which dilates less than 6 millimeter. And in all cases, it is best to do a very low parameter phaco. And whichever ports we are not using, we can seal it also. And it will depend on what situation arises during surgery, and we have to do it accordingly. But people less than 6 millimeter diameter, please always be careful.
Thank you, Jayanta. Thank you. Dr. Abhijit will be taking his favorite topic of reverse Kalman chopping.
Good afternoon. We have only 10 minutes and 2 speakers. Please.
Good afternoon, dignitaries on the dais and knowledgeable audience. My talk is on reverse Kalman faculty for posterior polar cataract. It's a video-based presentation. Posterior polar cataract is always looked as a fearful subject for even experienced cataract surgeons. The principle of the posterior polar cataract management goes like limited hydrodissection or almost no hydrodissection and reduction of mobility of the nucleus such that sorry. So The management of the posteropolar cataract, the principle goes as almost very limited hydrodissection or almost no hydrodissection, and rotation of the nucleus should be barely minimum or no rotation. And here we can accomplish it using a little innovation of the classical Kalman facultative, the reverse Kalman facultative. What's a reverse Kalman facultative? In classical Kalman facultative, the tip of the facultative faces forward. But in the reverse Kalman facultative, we just have made it reverse such that it will have an orientation like this. Below the tip is a reverse Kalman facultative. So here, because of this modification, entire phaco-fluidics and surgical principles changes. Here we have completed the initial hydrodissection. Then you have heard about the inside-out hydrodelineation, which I am going to do first phaco, then the hydrodissection procedure such that we cannot let the fluid wave to rupture the in between the cortical lamellae of the fibers. Then we shall hold the, this is what the reverse Kalman facultative is. I held the nucleus and did the shop. I did the shop in the other way. We have a triangular piece, a wedge, which can be removed. And this, the same facultative I have oriented in a different orientation, which is not possible with a classical Kalman facultative. Again, I have oriented in a different way and trying to hold the nuclear pieces and emulsifying this. And during the time of emulsification, my tip, the face of the facultative always remains towards the cornea. Now, once I have seen the sufficient mobility of the remaining of the nucleus, I have done little rotation, and the central hard nuclear part has been removed. I'm just fast forwarding the case. Now the epinuclear plate remains, and which can be also very easily handled by this reverse Kalman facultative. Again, keep looking the face of the or mouth of the facultative, which is most of the time facing the corneal surface, not towards the posterior capsule. And because of this orientation is something like the IA handpiece, we can use it for removal of the cortical fibers also. So to be called, can be called safe. So this is what we can have a wide approach with the with this reverse Kalman facultative. This is second case. So again, once again, in the similar way, inside-out hydrodelineation, we have engaged the nucleus, done the first crack. Once again, the next crack is done. We have such a good mobility of the facultative all around such that we can approach many parts without having to rotate the nucleus in front of the facultative. Now we have removed most of the nuclear elements, and subincisional epinucleus sometimes need to be mechanically dislodged and removed. In 20 cases of PPC during the time of preparation of this presentation, we had only 2 posterocapsular ruptures, which could be managed easily using a personal vitrectomy and 3-piece IOL implantation. This is just an introduction or showcase or making to understand that a reverse Kalman facultative, which is almost not popularly known of, has many advantages along with safety, and is not available also very easily, and so I can call it a dark horse.
Fantastic.
Thank you.
Fantastic. Now I call upon Dr. Nilotpal Bora. I would like to request him to keep the talk as short as possible because we have got only 5 minutes in our hand. Dr. Abhijit, it was very inviting for discussion, but we do not have time. There were a lot of things to be discussed. We'll discuss somewhere. Dr. Nilotpal Bora has got a presentation which was actually meant for a choroidal thickness in anisometropic and ametropic amblyopia, which he has prepared for some bigger platforms, but somehow the topic headlines has been little bit distorted. But he has asked for my permission and I have allowed him. Of course, I could not talk with the chairpersons. I have allowed him that something is to be delivered. But Dr. Nilotpal, you have very little time.
Next is for Gujarat. The people has come. If you allow, otherwise we can cancel the thing.
Actually, we got 5 minutes later, but we'll manage to give you within. You just give the summary.
I have already uploaded, but it hasn't come, unfortunately.
You just summarize.
Sorry, summarize. It is basically a choroidal thickness measurement in the Mongoloid races, which hasn't been done in Northeast India or probably eastern part of India. So we have made a choroidal thickness measurement with web source OCT, and we have found that it slightly corroborates with the international findings. However, we had found that in the anisometropic amblyopia, the choroidal thickness is thinner than the normal eyes. So we have 61 eyes in study group, and we had 22 eyes in control group. And we are planning for further studies regarding this, and including we also are measuring photoreceptor thickness in amblyopic eyes. Thank you.
So amblyopia is such a long-standing problem, but it always invites a better understanding, better analysis. Now I request Dr. Gauri to conclude the session.
Thank you, everyone. Especially thanks to all the speakers who have presented and all the delegates who have attended our session from Assam. So we have just...
Yes, I invite all the faculties to come here for a group photo.
One more announcement from...
There's a small announcement. There's a IDOC session at hall number, Trade Hall 6 tomorrow from 8 a.m. to 9:15 a.m. All are cordially invited. Please do come. Thank you.
All speakers, please. We'll have a photograph.